Muted.
If any, has your clinic already done around food insecurity, and what do you hope to do? Oh.
Can anyone, I'm going to unmute everyone. Would you let me know either through the text box or otherwise if you can't hear us? It's kind of hard to, that's proving of, it's back now. Great.
Okay. Hi, folks. So apologies if you couldn't hear us at that point, but we just went through an overview of the agenda, which you saw, and we'll now be diving in, starting with introductions. So we're going to ask that we all start by having you share your name, your clinic, your title, and a brief overview of your community health center's interest in food insecurity, any work that you've done previously, and really where you hope to go with this in the future. So you are all unmuted at this point, and why don't we get started? I see Reinhardt is on the line, so why don't we get started with you all?
Hi, this is Denise with the Reinhardt Clinic, and I have Katie here, our insurance navigator, Carrie, and Marge, our CEO. And our
welcome.
Hi. So we're just interested in improving overall health and access, to food. We participate in the social determinants of health questionnaires and find that food insecurity is a real issue for a lot of our patients.
Great. And have you guys previously done any either screening or interventions around food insecurity? I think I recall chatting with Marge about a community garden.
Yes, so we haven't typically done a screening, but we did team up with our local organic farm and purchase CSA delivered on a weekly basis in the clinic. And then we ran a nutrition class, and participants of the class would take home fresh vegetables at the end of the class. And we ran that.
Wonderful.
That's great.
Great. Exciting to hear. So it sounds like you guys are now interested in moving into the food insecurity screening portion and perhaps connecting back to that work around interventions.
Exactly.
Great. Okay, so I see it looks like we have Rogue on. Do you guys want to share a little bit about who's participating and what your interest is around food insecurity?
Hi, this is Rick Rank. I'm the Chief Administrative Officer for Rogue, and I'm the only one today listening, but we do have a group that's working on this. As a matter of fact, tomorrow we have a mobile food pantry that is on our lot the fourth Friday of every month that provides for people in the community and access to our patients, those that need help with having food supply or resource. And we're certainly consistently working on linking with other nonprofits in our communities to get, in order we can give our patients the ability to achieve self-reliance. So,
great, so great.
Yeah, it's an ongoing project, and so I'm very interested in hearing what others have to say on this segment with food insecurity.
Great, thank you. And Rick, can you, I'm not sure if I missed this, but have you all been doing anything yet around food insecurity screening as well, or has that not been part of the picture yet?
Well, we've been doing screening along the lines with the APCM project that's going on in the Prepare. So we're just in the middle of inputting all of that information on a focus on the patients, 100 patients that are filling out the Prepare form.
Great.
And then we'll begin running reports on that and addressing those by priority. We're not sure what those results are going to be just yet because we haven't run the reports. But I would imagine food insecurity is going to be one of the top ones.
Right. Great. Thank you. Okay, so let's see. It looks like we also have Tillamook on the line. Do you want to share?
Hi, it's Robin Watts. I'm Public Health Manager. I am sitting in for Marlene today. So, yes, we do screen our clients for food insecurity and make referrals. So that's kind of where we are right now. I'm just learning about all of this in more detail.
Great, thank you. And when you say make referrals, can you share a bit more about, are those referrals to resources in the community setting?
Correct.
Is that something, okay, got it.
Yeah, that's food banks, that's care, that's community gardens.
Got it.
That's
Great.
the meals at the churches, scrub club, all those things.
Great. And is that for all of your patients or for specific groups of them?
No, we screen everyone.
Fantastic.
Great. We're excited to have you. All right, so let's see. We also have OHSU Richmond on the line. Do you want to share?
Sure. Hi, my name is Treva. I'm relatively new to the Food and Nutrition Work Committee that we just have going now. We've been definitely food insecurity and addressing food access is a part of our strategic planning. And we have lots of very passionate members of our committee, from providers to leadership. And currently we're involved in a CSA for partnerships, CSA for Health Partnership program with Oregon Food Bank Garden, and it's also a partnership that involves an evaluation team from Portland State.
Great. Exciting. And sorry, I was writing while you were talking. Did you touch on any of screening work that is being done?
Are you screening?
Yeah. There's some screening. I don't know too much of the details of it, but there is some screening being done when patients are in the intake.
Okay, got it.
Yeah.
Okay.
But a lot of this is new. I mean, that's why I'm really excited to learn as well.
Great. Well, thank you so much for sharing.
So I want to pause this for 1 second so we can, oh, sorry, Treva, I didn't mean to interrupt you.
No, I'm done.
Okay. I realize that we haven't introduced ourselves,
and
I want to make sure that you recognize our different voices and who we are before we go further into this.
Great idea. So I'm Alicia Atalame, and I'm the Social Determinants of Health Manager here at the Oregon Primary Care Association, and you've been primarily in email communication with me so far. I've been setting up the calendar invites and can send along any materials or other resources needed as we move through the Learning Collaborative.
And Alicia has also been working a lot with our Prepare project. She's leading that here at OPCA. So if there are issues with that or integrating that with food insecurity, she's our greatest resource there. I'm Victoria Demchuk. I'm a policy analyst with OPCA, and I've been working, my interest here has been that I've been working with the food insecurity screening metric, which presently is a performance improvement project template for the CCOs. So I've been having other conversations with CCO partners and possible partners around this. So we are pretty much kind of the policy implementation arms of OPCA, both looking at food insecurity.
We'll be your partners through this Learning Collaborative. We will be bringing in other expertise, other folks from OPCA as we move through this, but we'll be the facilitators to move us through this work. So with that, I now want to move along, and it looks like I'm just going to keep you guys unmuted for now. It looks like we're not having any issues with sound, so feel free to go ahead and mute yourselves if there's a need, and otherwise we'll just keep it open to allow for dialogue. Okay, so I'm now going to move into a brief overview of the goals that we've outlined for this Learning Collaborative. And I really would like us to treat this, and as we move forward in looking at some of the more specific objectives, as draft goals, because I think, you know, obviously this is meant to be an opportunity for you all to learn and further your work. And from what we've heard already, it sounds like a lot of you have a wealth of knowledge and have already started to dive into the world of food insecurity screening and intervention in some capacities. So I'm really interested in hearing from you as we share what we've outlined, if the goals that we're setting forth and the work being outlined sounds like it will be helpful and meet the needs that you have to further your work. So high-level goals, as you can see here, we've outlined as really our first effort as a network of community health centers in Oregon to formalize an approach or some approaches, recognizing that there will be some variance among us, to both screening for food insecurity and interventions to address identified needs amongst our community health center patients. We're also hoping to identify resources that are necessary for implementation of food insecurity screening and intervention, and I would say that this exists at a few different levels, both in terms of what support do you and your fellow CHCs need from OPCA to get this work off the ground, and also kind of at a higher state level or systems level, what resources would be helpful from CCOs, from OHA, from the overall healthcare system structure to support your ability to screen for food insecurity amongst your patients and address needs. And then the third piece that we've outlined here is really around sharing what we learn. So we want to make sure that we're sharing those best practices and lessons learned not only with our other peers, other community health centers, but also with, as we'll get into, the OHA's CCO Metrics and Scoring Committee and other partners in the community that are really excited and interested in moving towards impacting the social determinants of health, and really see our work as an opportunity for laying out some foundational steps to getting there as a whole healthcare system. So I want to stop there and now ask for your all's feedback. Does this align with what you hope to achieve in this Learning Collaborative?
Yep.
Yes, definitely.
Great.
Sure.
All right.
And we're going to be bringing up another opportunity to talk about more specific goals of this Learning Collaborative. So if this generally aligns,
we'll get into the nitty-gritty in a bit later on. Okay, so next I'm going to briefly walk us through the proposed framework and structure. And as a reminder, this has been shared with you all previously via email, and we're just going to now revisit it. But if anyone would like me to resend that, I know that some of you might have been staff that have been brought in by others, so like if you haven't received all of the email communications up until this point, please let me know, and I'm happy to forward all of those materials outlining what we're about to discuss. So what you see here is an overview of the structure that we're proposing for this Learning Collaborative. And I'll start by saying that we've outlined about a 6-month time frame to do this work, recognizing that there's obviously potential for us to move forward beyond that in some additional capacity. So what we've outlined is a first phase starting now with this first webinar and extending through December, through which we'll do a series of about 4 webinars. The first 3 will be focused largely on our both outlining this Learning Collaborative to get us started and then sharing expertise and knowledge from folks that have varying or have different levels of knowledge and in different areas pertaining to food insecurity screening and intervention. So we'll start by hearing from Ned Mossman at OCHIN, who's going to talk very specifically and do a walkthrough of what it actually looks like to do food insecurity data collection. So what does that interviewing process look like, and how are we actually capturing the data within our EHRs, as well as reporting capacity and capabilities, which I think it sounds like, I think one of you mentioned you are at that point right now, so we'll be digging into that as a group as well. We'll also be hearing from Lynn Knox at the Oregon Food Bank that I think many of you have probably connected with at this point, and she'll outline a variety of resources and opportunities to connect patients with resources on the intervention front, so meeting needs once we've done the screening and identified that there is a food insecurity need. And we'll also be hearing from some clinics, potentially one in Oregon and potentially another in another state, that can really share an overview of how they've done this work from start to finish, so from the screening to the intervention. So we'll also be highlighting some kind of case study examples about how this might work. Again, you all will have opportunities as well throughout this process to share your own approaches. And then in December, we'll do a final webinar where we'll really come together and start planning our own pilots, PDSA pilot processes that will be taking place in phase 2. And given that some of you are already doing this work in various capacities, I think that's a piece I'd like to revisit with you all and figure out what makes sense, because it sounds like this might not be a first pilot for some of you, but perhaps instead an opportunity to either grow or improve the work you're already doing, expand to other populations for screening and intervention, et cetera. So we'll look at how best to target that to make sure everyone gets their needs met. Phase 2 then, after that planning in December, will begin in January of 2017, and that will be largely on your own, individually. It'll be an 8-week process through which you'll be focused on completing the pilot that you've outlined for yourself. So the goals around number of patients being screened, which patient population you're focusing on, how are you connecting those folks to resources, either within the clinic or very basic referral to food bank pantries, or perhaps more robust interventions developed through partnerships with other community-based organizations. So January and February will be phase 2 and focused on that pilot process. And we will reconvene as a group halfway through that 2-month period to share, kind of in a PDSA approach, to share our learnings so far, troubleshoot, brainstorm addressing any issues that have arisen, and make adjustments as needed for the second portion, the second 4 weeks of that pilot process. And then at the end of those 2 months, at the end of February, beginning of March, we'll come back together one more time to discuss our learnings and to talk about how best to share in a report really all of the best practices and lessons learned that you guys have encountered through this process. So we'll be doing that. We'll also, OPCA will be compiling all of that into a report to share externally with other partners and with the CCO systems, et cetera. So all of that to come, and we'll also check in with you all at that point about what needs or additional resources and support you'd like in the future. So that's what we've outlined as the overall structure for this Learning Collaborative, and again, we're happy to share all of these written materials with you so you have them on hand and have a sense of how this will go. So now I'm going to ask you guys, I have sent yesterday, I forwarded a draft Learning Collaborative Charter, and this is another item that, again, if you were just referred to this today, then you won't have received yet this resource from me. We will forward it along to you as soon as this is done.
Or actually, if you put your email address in the chat box, oh, so sorry.
So we can try and send it now, and if that doesn't work out, then we can definitely get it to you as soon as the webinar is over. But I'll also be sharing key pieces for us to review together now. And again, a reminder, this is meant to be draft, so we really welcome your feedback and thoughts in terms of what we've outlined here. So again, we've listed here that you can refer to the document we sent you all, and no problem if you don't have it, we will be sending it your way. So basically what we've outlined in the charter is a description of this project, including the high-level goals that we shared with you all, which at this point it sounds like everyone was on board with, but do let us know if there's any other high-level goals that you'd really like to be guiding this learning collaborative. We've listed the OPCA project contacts, Victoria and myself, Alicia, and we will be adding in, I think we're getting to now the final list of Community Health Center participants, you all, and the appropriate contacts. So we'll be adding those into the charter as well, so that you all have each other's information and know who your peers are as you take this work on. There's also a section of the charter that is really a business case for why we're taking on this work. And I'm not going to dig too deeply into that, but I'll just say that it focuses on really two aspects. First, as I think Reinhardt touched on, food insecurity is a significant need in our state and continues to be a significant burden for the patients we see in our community health centers. And I think because of that, this is an issue, a social determinants of health issue that has really risen to the surface as one that our CHC members would really like to focus on as they move further down the path of addressing the social determinants of health. In addition, there's also a really timely opportunity within our state at the healthcare system level as our CCOs and the Metrics and Scoring Committee really look to determine whether there can be a metric that is focused on food insecurity screening. And in addition to that, some supporting work around a project, which I'm not going to speak to because Victoria will be getting into that later on. But suffice to say that there's really this timely opportunity and a need, I think, for models around screening and intervention on food insecurity to be shared. And we see you all as a great group of folks to bring those best practices and lessons learned to light, and then for OPCA to disseminate and share those upwards to help inform structural systems changes and get resources to support this great work. So the piece that I do want to focus on now more deeply is the objectives that are included in the project charter. So I guess I do want to check in at this point. Can I ask, does anyone who doesn't have a copy of this document in front of you, can I ask you to speak up at this point and just let us know if you don't have it?
Yeah, this is Robin from Tillamook. I don't have any of the documents.
Okay, thanks, Robin.
And this
Anybody
is Rick
else?
at Rogue. I have not received any of the documents.
Okay. So I'm going to right now take a pause and send that to you both. So you'll have it for this conversation, and it sounds like everyone else has a copy in front of them. But if not, let us know and we'll send it your way as well.
And Triva, do you have a copy of this? I saw that you just dropped off and came back, and you might not have caught our question. So we're talking about the Learning Collaborative Charter, and I don't know whether you've had a chance to receive that or review it. Receive is really the question. Okay, we have Rick.
Okay, so we're sending that your way now. Victoria, did you want to chime in with anything?
I just wanted to add that in these, I've been interacting with the Metrics and Scoring Committee and the Technical Advisory Group for the Metrics and Scoring Committee to create a performance improvement project and scope it, decide on what are reasonable expectations and so forth. And one of the things that we've been hearing from different CCOs is that there is a lack of clarity or business case to them for responding to food insecurity. So we really hope that there is a possibility that in your experiences and what we can collect from you by the end of this pilot, that we would be able to share why and how this is effective for you as a healthcare provider to track food insecurity and to respond to it. There are several CCOs that just feel as if this is an issue that really should be responded to by asking people to step up their personal responsibility, which is very difficult considering that we're in a state that has one of the highest rates of food insecurity, especially among children. So a little bit of a broader scope right there in terms of what OPCA is looking for and why we're really excited that you're taking part and why so many of you are, and especially that so many of you are already engaged in food insecurity screening and intervention.
Okay, so I have now sent the charter to both Rick and Robin. Can you guys confirm that you've received that?
I'm printing it now.
Yep. Thank you.
Great. Okay. Okay, so with that, I guess I would ask everyone at this point now to scroll down to the section that says project goals and timelines, and then under that, a table that outlines short-term objectives. And this is really where we have, Victoria and I have mapped out the concrete work that we're hoping to achieve as a collaborative over the next few months. So you'll see that the first piece there is participation in 4 webinars. And I previously mentioned those when we went through the structure and the different phases of the Learning Collaborative between now and the end of December. And I do want to check in on that. I know that I've already received feedback from some of you that some of the later webinars do not work in terms of timing. So I'd love to check in with you on how we can manage that. We might set up an alternate time, you know, to go back over that content with you. Probably not live with the presenters, but certainly we'll record it and can share, and then, you know, verbally talk through any issues that arise. But I also want to encourage, if possible, for you all to have an alternate staff person to sit in your place if you're not able to join one of the webinars, because I think, you know, especially given all of the great expertise and knowledge that we heard you all are bringing to this, I think a lot of the value is going to be coming from the conversation that you all will be engaged in. So, so if there are webinars that you won't be able to attend, we can work with you on that, but I would also advise, if possible, that you have another staff person from your clinic to attend in your place.
Can I just ask a question? This is Robin from Tillamook. So you have one listed for November 11th, which is Veterans Day. We are not open.
Oh, okay. Thank you. Got it. Thanks for that heads up. So can I ask at this point, I don't think we've heard that doesn't work for anyone else. Can I ask anyone else on the phone have an issue with that date that they're aware of?
Reinhardt Clinic is open that day.
Okay.
It should work for me. This is from Richmond.
Okay. Okay. So we'll look at that. We'll see if there's we do have some external presenters joining us that day, so we'll have to check in and see if
she had a little bit of flexibility, but we'll see if she still does.
If there's some alternate dates that work, and if not, we will definitely work with you, Robin, again, like I said, to find another time to share that content. Any other questions on that piece, the webinars?
And can I ask everyone to send, as we talked about before, the best contacts from each clinic?
I have them now.
Okay, you have all of the best contacts? Great, because I know that Robin, for example, I don't know if you're going to be our long-term contact.
Yeah, to Victoria's point, I think I've been in communication with you all about who will be participating, but if there are any changes to that or any additional folks, please do let us know so we can make sure we're sharing all the materials appropriately. Okay, so the next objective that you see here is setting food insecurity screening and intervention goals, and we've outlined completing that by the beginning of December. And that would be, as I mentioned, really just the work that you'd be focusing on for that 2-month pilot in January and February. So if you might already be screening a certain population within your CHC, and this pilot might then be focused on expanding the screening to a different population, or to more patients within that same population, or building in an intervention component or additional intervention components. So regardless of what you outline you'd like to achieve during that pilot phase, we want to have that all mapped out by the beginning of December. We've outlined also by that time identifying and connecting with any potential community partners for intervention on food insecurity that you'd like to work with in that pilot. So I think some of you mentioned that you're already collaborating with community-based organizations at this point to address needs. That's fantastic. If there's additional folks you want to work with, you'll have the opportunity to start that process through this learning collaborative. But we also recognize that some of you might not yet be at the place where you want to take on working with external partners. So again, that's an opportunity but not a requirement. By the end of December, we're all going to be developing, or we'd like to be developing, community health center specific workflows to support your work around food insecurity screening and intervention. So this is out of recognition of the fact that you all will have possibly slightly different approaches to screening and intervention in your own settings, whether it's through which staff role is doing the screening, at what point during a patient visit, to, what is the intervention that patients receive when they're being identified as having food insecurity, whether it's, to a food bank pantry, to a nutritional class, whatever the resource might be. So mapping out those workflows will take place over the month of December with our support. And then the last short-term goal is participating in that pilot that we've been talking about in January and February. And then the long-term goals that we've outlined here are really just, we hope that you all will be willing to participate in a dissemination event, and that could be at an already scheduled, likely will be at an OPCA gathering of some sort, maybe through one of our peer learning networks or some other gathering where we hope that you can share your work with your peers. And then also working with us to compile all of your learnings and best practices for us to develop into a report to be shared, as I mentioned, or as Victoria mentioned, with the Metrics and Scoring Committee and other partners, CCOs, et cetera, that would like to support this work. And again, we see that really as a key opportunity to get you infrastructural support and resources to really aid you all in doing this work moving into the future. So I think it's really important that we share upwards and outwards the work that you'll be doing here. So I'm now going to pause there and ask you all to share your thoughts on these objectives. Actually,
it sounds great to me. This is Treva from Richmond again. It sounds great to me. I think that the idea of being able to capture data in a way and make a strong case for greater investment in intervention programs would be fantastic. I know that that's something that the long-term financial structure is something that a lot of different partners, including ourselves, are hoping to establish.
Great. Thank you, Treva.
Yeah.
This is Rick at Rogue. It sounds great. It's something we're working on, but as far as me personally continuing to be the main contact, I'm not sure. I just found out about this yesterday. We definitely want to participate, but there could be another main contact.
Great. Thanks for sharing that. And Rick, I've been in contact with William North as well, so I will, we'll continue to work together to figure out who ongoing contacts will be and make sure that we get you all resources that are needed.
Yes, okay.
But in terms of the objectives outlined, that all sounds good to you?
Yeah, I'm pretty sure it's work we're doing anyway, so I think it will be fine.
Great. Any other feedback? Okay, and I just want to check in, you know, really probing here, but what about timeline? Does it seem reasonable and realistic that we've outlined, you know, this initial few months of sharing content and planning with you all, and then engaging in that 2-month pilot period at the beginning of 2017? Does that all sound reasonable and helpful as a timeline?
I should be able to do this work. I mean, right now, a lot of the labor that's involved for this stuff is sort of volunteered, or people using their admin time to do it. We don't necessarily have a dedicated individual to execute this stuff. I'm sort of the de facto person for that. So I'm going to say that we're committed, and I'm going to do the best I can to follow through on everything. And I also just need to be completely transparent and say there might be limitations, but I'm definitely committed to it, and I know that our food and nutrition committee will be all over this. Definitely the enthusiasm's there.
Great, thank you, Treva.
And Treva, if there are any other materials, or if sharing this, if sharing our project charter would be helpful with your peers to make sure that you can carve out that time, let us know what we can do to help.
Okay, yeah, that sounds great.
And the last thing I'll mention on that front in terms of sharing as well is that, so this really came out of your executive directors participating in the data transparency work group and identifying food insecurity as an area that they wanted to start or continue or broaden work on. So to that end, you know, that's where we kind of initially were referred to the list of community health centers that would want to participate and how you all got involved. We will be sharing back progress to those EDs, perhaps quarterly, perhaps at the end of the Learning Collaborative, but somewhere along the way on the data transparency work group calls, because they'll be really interested to hear how this is coming together and all of the great work that you guys are doing. So we really look forward to working with you all, to you sharing your progress along the way, and to us being able to relay that back to the leadership.
Yeah, are you talking about EARN?
I'm sorry, what?
Are you talking about the executive director for Richmond?
Well, no. So I was speaking broadly about all of the executive directors, and in the case of OHSU Richmond, I think that your involvement actually came from conversations with Lynn and Brian Frank.
Yeah. Thank you.
Okay, so I think at this point we can move on, and I want to check in on time. So we have about 15 minutes left. So with that, let's move into now talking a little bit about the why and the what is food insecurity screening.
So it sounds like to me that you don't really need me here, because everyone is already involved in some degree of food insecurity screening. So I'm just going to run through this pretty quickly as a reminder, a refresher on why we're doing this important work. So, and also to keep us timely with the USDA's evolving definitions. So the USDA is now kind of using both food insecurity and low food security to mean food insecurity, which they define as a household level economic and social condition of limited or uncertain access to adequate food. And they are no longer using the word hunger for very low food security. They're now being very explicit that very low food security is a thing itself, that very low, disrupted eating patterns, reduced food intake, reduced access to food, which results sometimes in hunger. So I think all of you know that these are issues that are prevalent among our populations and the individuals we serve, and that food insecurity and low food insecurity and very low food insecurity are all related to not having enough access to resources. So as one thing I wanted to do a quick comparison is how we can compare CCO populations and non-CCO populations and see a significant difference between the rates of food insecurity among those folks. So among OHP adults, for example, the rate of hunger or very low food insecurity is almost half of that. Almost half of the people who are food insecure at all are hungry or exhibiting very low food insecurity. It's striking. this is our patient population. This is from the Medicaid BRFIS, so the Behavioral Risk Factor Statistical Survey. So it's a general public health survey that was conducted only on the Medicaid population in 2014. These are new enrollees. This is after we expanded Medicaid. This is not the 100% of the federal poverty line group. And it still has a really high rate of food insecurity. And then we can compare that to adults in Oregon, where the rate of very low food insecurity is the same as the rate of prevailing food insecurity in our Oregon population among adults. And when we look at this among Oregon households, we're adding children, and we see some lower rates of food insecurity. Other factors that we have to consider as we think of Oregon, which has this distinction of being the only state whose rate of food insecurity went up in the last year, from the 2014 to the 2015 numbers.
Alarming.
Yes, not great. Something that we're trying to work to fix. We have also pretty high local housing costs. Those are only increasing. Some low and stagnant wages for this group, so we're going to see some changes in the higher minimum wage over the next few years. And a lot of difficulty accessing food in rural communities and a high rate of food deserts. So this is going to be a persistent problem. It hasn't just been a persistent problem, but it's going to take a lot of work to get over. And one thing that perhaps gives me hope as an upstream intervention is that when I look at food insecurity among the adult population, it affects younger adults. So 27% of the folks who are 18 to 24 are food insecure, and then from 25 to 34 are food insecure. What we do see is that in families there is a pattern of parents giving up and increasing their food insecurity on behalf of their children. So we might be seeing a little bit of that, but we also see much higher rates of food insecurity in households that our clinics are likely to see. Single parent households, headed by either men or women, single person households, households of color, and households with income less than 185% of the poverty line, so the SNAP population. And if we consider this distribution, there's a lot, even in the wider population, there's a lot of potential to affect this population and their long-term health. The screening, we are recommending a USDA 2-question screen. I think all of you have seen this. Actually, can any of you speak up if you are not using this 2-question screen? Or if you're using a different form?
Not using this screen.
Okay, can you tell me who you are?
Yep.
I think that was Treva.
Okay. Treva, we're going to connect later about which screen you are using. Anyone else? So I'm going to assume that everyone else is using the screen. Treva, for your information, this is a short form of the USDA 18-question screen, which was shortened into a 6-question screen. That's the one used for the BRFIS. And then these 2 questions are seen as very effective at gauging food insecurity.
Perfect. Thanks.
They were also recommended by the American Academy of Pediatrics for screening children. So they're pretty straightforward. Sometimes we see variants that people ask for a yes-no response rather than often, sometimes, or never true. What I've heard from other child hunger groups is that they recommend the often, never, sometimes true, because that has a higher chance of catching someone who doesn't want to admit food insecure, but has sometimes been food insecure over the last 12 months. They're not comfortable saying, yes, I have been food insecure. And if we're targeting getting folks in for interventions because they don't have food, this is a great way to do it. So circling back to this food insecurity PIP, which is the Performance Improvement Project, OHA's Metrics and Scoring Committee has been working on food insecurity as a potential metric. We are an on-deck metric, but one of the issues is that we need to have a consistent and piloted screening that CCOs could turn on and take out of its box. So I and some other colleagues have been working with the Oregon Health Authority to develop this methodology, which is known as the Food Insecurity Performance Improvement Project, and it's now available for CCOs to use on some aspects of their populations. It would be used on a practice level basis, so one of the things I'm hoping that we can do in this pilot is pilot that document, which we're going to send out to you afterwards, within your practices and see, are there glaring issues? Are there significant other kinds of information that should be included as part of a toolkit? What other supporting information and support would you need? And it uses that same 2-question Hager screen, but is open to other screening methodologies. And generally, this is a very top level, what does screening and intervention look like? By the Childhood Hunger Coalition, suggests the same set of questions and reminds us that we should be considering not just the food insecurity screening, but how it affects the health of the patient. So is there an issue with growth? Are there other health, immediate or long-term health consequences, as well as providing resources and intervening? But making sure that we use food as a diagnostic tool. The last consideration, I know that you're all probably aware of this since you are doing food insecurity screening, is that talking about any kind of lack of resources, especially where people have a great responsibility to their families, is a sensitive topic. So finding ways to ensure that you're connected and respectful in the interaction is critical. We are presently developing, do we already have them? We have empathic inquiry resources for interviewing around the social determinants of health, and we'd recommend that you can look at these and maybe adapt them for your work with food insecurity.
And that's another resource that we'll be sure to share with you all in the months to come. They include, we've developed a lot of resources, including a demonstration video that some of you have or will see if you are participating in the APCM initiative. But we'll definitely share all of those out with you, as we think they'd be really useful here.
And just continuing to think that food screening and intervention can be done at different levels of engagement from the practice side. So whether it's just adding questions and assessing for food insecurity, intervening or intervening and following up, those are all possibilities. We support practice clinics at any level of that. And I'm going to do a super quick, the PDSA approach. What we're going to do here is, I'm going to gloss over this just as a refresher, and Akira, our colleague who works with quality improvement at OPCA, will be joining us for the December session to really talk about pilots, what your plans are, talk about goals, and how we can have a PDSA protocol that supports you and your goals without changing too many factors too quickly. So how will we pilot food insecurity screening and intervention? Selecting populations of focus, unless you are doing everyone. Working on that PDSA plan through December, beginning a pilot in January, checking in and sharing results. We covered this before with Alicia, just touching base, and we still need to decide on our date in December. So if there are times that do not work for you or your team, please let us know, because we'd like to make sure that we have a way to connect with all of you, and we could set up a separate phone call or some other way to share that information otherwise. I think that it's really valuable that we share our different plans with each other, but we can do that not all in a webinar if necessary. So a few examples. Considering who administers the food insecurity screening, checking for comprehension, checking interventions, and also checking, but trying to, one thing that we're asking for is maybe just changing only one of these aspects at a time. So you can assess whether your intervention is, or your correction and refinement is really helping the work that you're doing. Refresher, PDSA stands for Plan, Do, Study, Act. I consider what we're doing right now our preparing to plan portion, and then we would hope to do at least 2 cycles of this, the first in the January through February, and then February through March, or for this year, February, depending on how you're doing this. And again, a quick refresher and a potential flow sheet. So, looping back, we're running out of time. It means that I'm speaking too quickly. I want to talk about our next gathering. We've already talked a little bit about our plans for the next few webinars. One will be October 17th. We're going to be asking around about the November 11th gathering and whether that works for everyone or what we can do. And we might be able to reschedule that. And I want to chime in here and say that I think October 17th
is going to be a really great day. We're going to have, as I mentioned, Ned Mossman from OCHN doing an actual live walkthrough of the food insecurity screening questions within OCHN EPIC, and talking through that data collection and reporting capabilities. So I encourage you, if you all do not think you'll be able, if any of you think you won't be able to join, let's connect and think about perhaps an alternate staff person from your community health center participating, or other ways that we can make sure you are able to be involved in that in a meaningful way. And then, as we mentioned already, we will, in addition to the already planned webinars in October, November, we will be coming together in December to really do some hands-on pilot planning. That's when Akira, our QI person, will be joining us to help us move through that process. So that timing hasn't been scheduled yet, given that it's a busy month and everyone's schedules varied. I'm thinking that what I might do just for that one meeting is put out a doodle to all of you and ask you about available times so we can get that webinar in December scheduled at a time that works for everyone, and we can map out our pilots. So stay tuned for that. So with that, any questions from you all in our remaining 3 minutes? Sorry we moved so quickly there at the end, but I want to ask you all if you have any questions at this point.
Reinhardt does not. Thank you.
Thank you.
Nope, no questions.
Okay. All right. Well, you also feel free to email if anything comes up, and we'll be in communication leading into our next gathering in October. And thank you all again for joining us. We're really excited to be engaging in this work with you over the next few months, and we will be in touch.
Thank you so much. I'm also very excited. I think this is going to hopefully make a great difference in people's lives.
Great. Thank you.
Thank you.
Yeah. Oh, actually, I do have one question, but I can email it to you. It's regarding why, if you guys know why, you know how you said we're more food insecure than last year, and we're like the only state or whatever that did that. I'd like to know some of the determinants around that, but maybe we can email about that in the future.
Yeah, let's email about that. I don't know.
Okay.
I was just looking at the USDA.
Okay.
Looking at the USDA report, and it flags Oregon as the only one where over a rolling 3-year average, our 3-year average went up, which was disconcerting.
Yeah, very. Okay, great. Thank you.
Thanks.
Thanks, guys.
Thank you. Okay, so